Behind the Knife, the surgery podcast. Relevant and engaging content designed to help you dominate the day.
Hey everybody, I'm Ayman Ali, one of the Behind the Knife fellows. Today, we'll be introducing our new AI Journal Club series, where we discuss a clinical case and AI-related papers and tools that fit into the patient's care. AI in surgery is still very much in its infancy, and there are many papers that are being published almost daily. Today, I'm joined by some co-hosts from Oregon Health and Science University. From faculty, we have Dr. Ruchi Thanawala, who's a thoracic surgeon at OHSU and also founder of Firefly Lab, an AI-driven platform that is built for competency-based medical education. In addition, she directs the Surgical Data and Decision Sciences Lab for the Department of Surgery at OHSU.
Hi, thank you for having me on here. I'm very excited to be on this podcast with all of you.
And we're happy to have you. And we also have Dr. Marissa Sewell, a PTY4 general surgery resident at OHSU.
Hi, very happy to be here. Thank you for having me.
So let's just start right with the case. Imagine we have a 52-year-old woman with a past medical history of hypertension, hyperlipidemia, chronic obstructive pulmonary disease without needing home oxygen, and a recent admission for a left upper lobe wedge resection for a suspicious nodule. She was discharged on postoperative day 2 without any issues, but now comes into the emergency department on postoperative day 5 with dyspnea. Her initial vital signs and physical exam are notable for a temperature of 39 degrees Celsius, a blood pressure of 90/50, a heart rate of 115, an oxygen saturation of 87% on room air, and left calf erythema and swelling approximately 4 centimeters greater in diameter compared to the contralateral side. Dr. Thanawala, what are some key differential diagnoses and maybe some more rare considerations?
Oh, so this is super interesting. While this is a hypothetical patient, for me as a thoracic surgeon, many things come to mind. I get a little tachycardic on my own because there's something bad that's really happening to this patient. So my mind really goes to PE and pneumonia, either one or the other, maybe even both. I mean, the calf tenderness off the bat has me worried that she has a DVT. That could have embolized, into a PE. Rare considerations, you ask. Well, without getting too much into the weeds of thoracic surgery, when you do a wedge, there's a question, is the remaining lung, did it torse for some reason, like the lingula? And lingular torsion could, present in a very similar way. But you wouldn't expect the calf erythema and swelling. So other things, early empyema could make her sick like this. I think there are a lot of things to consider.
Thank you, Dr. Thanawala. Those are all very important considerations. Before the thoracic team has been consulted as part of the initial workup, in the emergency department, basic labs, an ECG, and a chest x-ray are ordered. Additionally, the emergency department physician performs a point-of-care ultrasound of the lower extremities.
Awesome, and this is a great segue into our first study. So in January of 2025, a UK-based team published in NEJM AI, New England Journal of Medicine, the results of a multi-center, double-blind study evaluating AI-driven detection of proximal DVTs. Their work was to evaluate a software called AutoDVT, which was developed by a company called ThinkSono, and essentially it couples to a handheld ultrasound device and is intended to allow non-radiologists to perform 2-point compression ultrasounds and diagnose in real time a proximal DVT. The researcher is meant to take an ultrasound on the groin and move the probe as the software directs it and compress it until sufficient data is collected, which is indicated. The AutoDVT in this study was performed prior to a clinical ultrasound, and the results of it was not disclosed to anybody and not used for clinical care. Then, the AutoDVT results were compared to clinical ultrasounds. The primary outcome of this study was the sensitivity of the algorithm, and prospectively was set to be 90% or greater, which resulted in about 400 patients being enrolled. The data gathered by AutoDVT was then also reviewed by radiologists to ensure that there were no image quality capture issues that biased the studies or results. Unfortunately, the AutoDVT had a 68% sensitivity and 80% specificity for a proximal DVT, and out of these 31 positive scans, true positives, 10 were mislabeled as negative by AutoDVT, and one of those patients had a normal D-dimer, which made the diagnosis even more important. Retrospective clinical review of the images taken by AutoDVT, however, were 85% sensitive, so the images should have been adequate enough to have a higher sensitivity. For these reasons, the desired 90% sensitivity was not achieved, and this was published as a negative trial, as that sensitivity is just not acceptable in the setting of the DBT rollout.
So this is a great study to discuss for multiple reasons. And now I get to put my hat on as an informatician. Um, there are really two aspects to the study. First, one is if non-radiology trained staff can actually get the right images to make a diagnosis using this tool. Then the second part, really, which gets into the AI part, is the use of a convolutional neural network algorithm from the software, whether that can actually detect the DBTs based on the available images. This really highlights, I think, one of the key challenges in AI. An algorithm cannot overcome data quality. So if the data doesn't actually have the answers in there, the algorithm can't come up with it. The algorithm doesn't know what it isn't shown in most circumstances. The fact that 63 of 295 results were discrepant compared to standard compression ultrasounds means that there is an important human factor that cannot yet be automated out to an algorithm. Knowing that we haven't achieved it yet, that auto DBT hasn't achieved it, doesn't mean that it can't eventually be achieved. I think the importance of the study, while it's a negative result, is that we just have more work to do. I mean, it's a great ambition to make ultrasound for DBT accessible for use by non-radiology trained staff. I take care of cancer patients every day, and DBTs are a huge concern for cancer patients and other high-risk postoperative patients. When we do get to a 90% sensitivity and beyond, that's when we're going to be able to really implement this for our patients and increase access to diagnosis and treatment for DBTs. Anyways, really, really good study, and I think a really important thing to discuss.
Yeah, thank you for those points. I think that when this eventually is achieved, it has so much potential in many different settings. And so I'm excited for the next step. Now, continuing with the case, the emergency department orders a clinical ultrasound of the leg and also a chest x-ray. And then chest x-ray brings us to the next clinical study, the CHEXNet paper. Marissa?
Sure. So in 2017, a group from Stanford published a paper which described the performance of their model, CHEXNet, a convolutional neural network, which was initially designed to detect pneumonia, and then they then expanded it to detect 14 different chest pathologies in an AP chest x-ray. This was a landmark study in computer vision in medicine, has been cited over 1,400 times. Essentially, the authors built their model using a very large NIH dataset of over 100,000 chest x-rays from over 38,000 patients, which was annotated to clinical pathology from their radiology reads using natural language processing. This model was validated using a dataset of 420 representative images with a group of senior cardiothoracic radiologists who read them and set the reference standard. The model's performance was then compared to the performance of a separate group of 9 radiologists, including 2 senior radiology residents. The model performed quite well. The radiologists performed better than the model in describing 3 pathologies: emphysema, hiatal hernia, and cardiomegaly, and the same in 10 pathologies. The model performed better than the radiologists in detecting atelectasis. Of course, this model is imperfect, as it was built using only AP chest x-rays, and prior studies and patient histories were not included either in the development of the model or in the radiologist's interpretation. However, this study has inspired many subsequent studies in practical applications of computer vision in medicine.
So you guys, this is another excellent study for us to talk about. I think this is a great study for multiple reasons. First, it's a non-inferiority study comparing an AI-based algorithm, another convolutional neural network, against really highly trained radiologists. I actually think the fact that it was developed on AP chest x-rays is a big positive. So many of our patients that are in the hospitals are actually getting AP chest x-rays. I mean, they're getting portable x-rays, they're in their beds. Chest x-rays also are one of the most common radiographs done in the US and probably worldwide. It's far more accessible than a CT scan. I think it's super interesting that the algorithm was better than the radiologist at detecting atelectasis. I'm not really sure why, but some things that kind of come to mind is whether radiologists, being humans, have a shared mental model with other physicians and say, what, guess what? I don't need to point out that there's atelectasis. The physicians probably expect that. So as humans, perhaps what we're putting in these radiology dictations is actually related to the different findings, the things that you wouldn't expect, whereas the convolutional neural network algorithm has no idea about that mental model necessarily. Now, for some of the other things, I think it's pretty impressive that the algorithm was able to perform as well as a radiologist on some pretty significant findings, such as pulmonary edema, pleural effusions, fibrosis, infiltrates, masses, so many of these, up to like pneumonia and pneumothoraces. These are really clinically significant findings that this algorithm was really effective at identifying. I can totally see why this paper has been cited again and again, because I think it really has a really super strong methodology, a really well large annotated data set. Going back to what we talked about with the previous paper, an algorithm cannot overcome the quality of the data. This paper provides really solid data. And I think as a result, they have a paper that really has the ability to kind of change the way we see how these convolutional neural networks can be applied to chest imaging. I mean, it's something I probably would try and use to see what the results are for some of my patients.
Yeah, I mean, totally. This is extremely exciting, and it's been exciting, and there's a reason this is a landmark paper in the field. I think it's going to be really interesting to see how we tackle imaging modalities that are not as commonly obtained, but that have maybe more data within them, like an MRI. But nonetheless, this is a really promising start, and one that can actually be used today. So to wrap this case up, as soon as that chest x-ray was taken, an automated notification went to the ED physician demonstrating concern for pneumonia. The physician glanced at the chest x-ray to confirm the finding prior to the radiologist's official read, begins antibiotics, and continued the workup and consultation to the appropriate services. We won't really follow this patient's journey much longer, as her job demonstrating a few interesting AI studies is complete. Any last comments, Dr. Thanawala or Marissa?
Well, I think both of these studies are really impactful contributions to the body of knowledge and the work in AI in medicine. We don't always need positive results to learn from. It's actually all a work in progress. And the more conversations we have like this and review the great work that we talked about today, the more we can all move together incorporating AI and other advanced tools into our daily practices.
Well, that's great. And that's all for this episode. And from Behind the Knife, dominate the day.
The day.
Be sure to check out our website at www.behindtheknife.org. Download our free app available for Apple iOS and Android. Simply search for Behind the Knife in the App Store or Google Play to download the app. In the app, you can listen to our episodes, watch high-yield videos, and even access our premium content, including our oral board reviews and trauma video atlas. You can also follow us on Twitter at Behind the Knife and on Instagram at Behind the Knife Podcast. If you like what you hear, please be sure to leave us a review. Content produced by Behind the Knife is intended for health professionals and is for educational purposes only. We do not diagnose, treat, or offer patient-specific advice. Thank you for listening. We appreciate your support.
Until next time, dominate the day.